So EKG findings when you have an MI, okay, again, it has to be lead specific. So when your patient comes back for an MI, you want to put lead specific monitoring in place so we can identify if they have changes. And how do you know that it is like an MI happening in front of you? They came back from cath lab. Can they have an MI after cath lab? I thought they fixed it. Yes, they can. So we want to make sure we're monitoring, and if we see something suspicious, we're going to then get a 12 lead. And you're looking for changes in 2 or more contiguous leads, right? That's the word. All right, so normal findings. How do you know this is normal and not abnormal? Well, T waves are always asymmetrical. So if you split this in half, it is not a mirror image of itself. It is asymmetrical. It has a little slower upstroke and a faster downstroke. That is normal. If it is symmetrical, that's a problem. That is a sign of something wrong. Okay, so you can see this one is symmetrical. All right, it's broad, it's symmetrical, and it's upright like that. That could be an MI happening in front of you. Okay, and what else is normal? ST segments are always isoelectric. So isoelectric meaning what? It's the flat portion of the EKG, right? These are your isoelectric, that's your isoelectric line. Your ST segments should be isoelectric. There are variations where you can have like early repolarization in young kids and such, and like left ventricular hypertrophy, right ventricular hypertrophy can cause changes, but for the most part, it is going to be a flat line. And when that line starts rising, that's when you start concerned about ST elevation, or if it starts getting drawn down, that's when you consider about ST depression, right? That ST segment. And it's really at a specific point along the line. So if you were to pick a certain point to grab your fingers and pull it, that is called the J point. We're pulling it up from a specific point. Is where the QRS ends and the ST segment starts, is specifically called the J point. All right, so we just grabbed it and we just pulled it up, right? Sometimes it's like all the way down like this, right? And the ST segment is all the way up. And it's like, well, that's normal. That's fine, right? So we want to make sure, like this one right here, is that ST depression? It kind of looks like it is, but we're going to talk more about that when we talk about what the normal variants are. So J points are the point at which the ST segment is being pulled up or being pulled down. And then Q waves. So we'll talk more about Q waves, but Q waves are this big dip right here, your QRS complex. You have this huge negative deflection before the rest of the QRS complex. So if it is very, very deep, we can measure it, and if it's more than 25% the height, that is considered a pathological Q wave, a Q wave that is bad, right? So what is 25%? It used to be 1/3. I don't like 1/3, doesn't feel right. I like 25% better, right? Because 1/3 is 33.33, and you add it by 3, it doesn't equal 100. It's a whole thing, right? So 25% makes a lot more sense, right? So for instance, we got all these boxes right here. We got 12 boxes up, and we got 8 boxes down, right? So that's 20 boxes, right? That's 20 millivolts of QRS amplitude. So if the bottom half is more than 25%, that is considered pathologic. So what's 20% of 25 or 20? 10% is 2. 2 times 10 is 4, right? So if it's more than 4 boxes, that is, in this case, if it's 20 millivolts, that is a pathological Q wave, right? The other piece that's pathological, the Q wave, is not just that it might not be all the very, very negative, it could be wide. That's also pathologic. So it's more than 1 box, specifically 0.03, but we know 1 box is what? One little small box is 0.04, right? So if it's more than 1 small box, it's really getting there. That's something that is considered pathological, right? So you can see here, we got this nice deep Q wave right here. Look at that Q wave is even more deep in number 6. Look at this Q wave. That's huge, right? And this one also has some T wave inversion, right? Definite ST elevation on these guys here. All right, so that's the idea behind our normal segments that we can recognize, right, versus, normal. And obviously you have tombstoning, that's a sign of ST elevation, a really bad ST elevation. But Q waves are also valid ways to assess if someone has an MI or not. All right, so T waves. So a little bit about T waves. We're going to focus too much on them, but T waves are, again, they are normally upright and asymmetrical. So you can't split them in half and be a mirror image of themselves. If they are, that's a problem. Okay, so it's repolarization. Repolarization is where all the positive electrons are going back in the cell. So it's creating a negative environment, right? And that negative environment is moving away from the electrode. The electrode's positive, and if I take negative or cold water out of my positive bath, That makes my impulse what? Positive, right? So I'm just like taking the cold water out of my bath, if that's something you could do, right? So if you could take the little cold ice cubes out of your bath, I guess, right? That is what's going on with a T wave, right? We depolarize, that's a wave of positivity towards this electrode right here. And then we depolarize towards my electrode, that's a QRS complex, right? And then I come away from it, right? I'm going away from my electrode. My electrode is positive, and this was negativity, leaving my life, right? Leaving my bathtub. And that's going to make my T wave upright, right? So that's how a T wave is positive. And then ischemic T waves, well, whenever you have ischemia in your cells, do they work good? No, so they are faulty. They are no longer at negative 70 millivolts like our resting membrane potential is, right? They are funky. They're not really going all the way back down to negative. They are constantly releasing positive energy. It's like, why is positive energy coming from something that's ischemic? No, it's just a little positive energy because it's like leaking stuff. The sodium ion channels, the calcium channels are not doing their thing, right? It's leaking positive energy, right? So this is inherently depolarized, and it's causing this positive energy to get released. And when it's time to repolarize, it's not going to be perfect anymore. You're going to see positivity happen first, right? And also, it's not going to go the right direction, right? It's going to be reversed even. So the repolarization is reversed, and therefore you're going to get a inverted T wave, right? So it's a wave negativity towards the electrode instead. And then just a note on other things to look at T waves. There's a little more advanced where you look at concordance or discordance. You're looking to see, is everything going the same direction or is it not going the same direction? So when you have like bundle branch blocks and pacers, you no longer get a normal EKG, right? It looks all wonky and wide and such. So how do I know they have ST elevation or not? So this is what we use. It's called Scarbosa's criteria. It's a way to assess if they have ST changes or not, right? And it's something you would assess, you would just look up online, MD Calc, you look it up and say, hey, what's going on here, what's going on there, and that would tell you if you have Scarbosa's criteria or not. It's like 5 points or 7 points or something, right? But basically, when you have a left bundle branch block or you have a pacer, it's going to cause a abnormal depolarization, repolarization, right? So it's going to be the opposite of what you think. So your QRS is going to be nice and negative, and your T wave is going to be going not inverted. It's going to be discordant. It's going to be opposite what you expect, right? Because you're no longer going through the normal pathways anymore. All right. So you should have discordance. That is normal. If you have concordance, that is a problem. It means they're going the same direction. So you can see this is upright and that's upright. That is not normal for someone that has a pacemaker or a left bundle branch block. So if that's happening, that is a problem. If they have a really, really profound ST elevation, because usually a left bundle branch block, you're going to see ST elevation. It looks like 3 millimeters, 5 millimeters even. But if they have more than 5 millimeters on a left bundle branch block, that is considered a sign of an MI, right? So that is something that we look at when we are assessing, do they have an MI or not? Because oftentimes you'll hear like older providers, they'll say, oh, if they have left bundle branch block or pacer, you can't tell if they have an ST changes or not. But this thing came along, and it is a way to assess if someone has EKG changes, right? So yeah, there's different points assigned to it. Do they have concordance? Do they have this big ST change? Those, and specifically V1 to V3. They're looking at these things, and if they do, that can be a sign they have an MI and needs to be escalated. Okay, so abnormal T waves. So T wave inversion, right? It's normal to have T wave inversion like V1, lead 3, but for the most part, if you have T wave inversion, that is a problem, especially if it's symmetrical, right? Symmetrical always means ischemia, right? And new T wave inversion is always bad, right? You shouldn't have new T wave inversion. So you look at the previous 12 lead, all the T waves were upright, and this 12 lead, the T waves are inverted, right? That's a problem. All right, so, and usually, yes, it should be contiguous. It should be in the leads that in a certain area of the heart that's causing problems. All right, the other reasons why you might have T waves that are inverted are with what's called cerebral T waves. When you have a huge insult to the brain, like a hemorrhage to the brain, it causes really, really deep T waves. You have this T wave inversion, but it's not because of lack of flow to the heart. It's because of a huge SNS cascade throughout the body because of this bleed in the brain, and it's going to cause your T waves to look like this. You don't see this in MIs. MIs, they're a little more subtle, like this, right? Or T wave like this. They're symmetrical and inverted. But if they're super, super deep, that's considered cerebral T waves, and that's time for a CT of the head, right, to figure out, make sure there's nothing else going on. All right, and then what else? Yeah, T waves inverted post-cath, they may still be there. It may take a while for that T wave to bounce back, or it might not, right? So that's why it's important to look at historical 12 leads. And then hyperacute, or really, that means like in the first 4 hours, broad, wide T waves, that is an acute MI. So here we got nice wide T waves right there, and we got some peaking happening, right? We got nice wide, broad T waves right there. So if they're wide, broad, and symmetrical, and upright, and peaked, that is considered an acute MI. But what if they are like this? That's peaked, that's tall, that is hyperkalemia. So the difference between hyperkalemia and acute MI is the width of the T wave. So if it's narrow, it's what? Hyperkalemia. If it's wide, it's an acute MI. And upright, right? I thought all T wave, it was all T wave inversion. Now there's, when you have upright T waves that are wide and narrow and peaked, sorry, wide and peaked, that is a consideration for an acute MI, especially in the early stages. The other thing, the way to tell is when you have peak T waves and it's only in 2-3 AVF or it's only in 1 AVL, that's probably the area that's getting an MI, right? When you have hyperkalemia, you don't have hyperkalemia of the LAD, right? You don't have hyperkalemia of the right coronary artery. It's hyperkalemia through the whole body and through the whole coronary system. So it's diffuse peak T waves when you have hyperkalemia. So peak narrow T waves in most leads is hyperkalemia. And then we have de Winter T waves. So these are, it's an equivalent to a STEMI, just like a left bundle branch block is an equivalent to a STEMI. You have these de Winter T waves in red here. That is also an equivalent to a STEMI. That should mobilize a cath lab. That is something that requires intervention immediately. Okay, so what is de Winter? And again, you probably just going to look this up when it happens. But de Winter T waves are when you have this upsloping happen. It looks like ST depression. So right here, de Winters, right, where am I at here? Is Wellens, biphasic. Here's my de Winters. I thought I had them here. Maybe it's on the next slide. All right, so anyways, they have this upsloping ST depression. Sorry, I can't see it here. ST depression. There's a flattened T waves like a hypokalemia. But we have our Wellens here. Maybe it's the next slide. So I need to get an example of this one. Sorry about that. But I'll point this out coming up. Right? So it looks like really, really profound ST depression, and then it slopes all the way up to a peak T wave. And then flattened T waves. If it's in most leads and it's flattened, that's hypokalemia, right? Hyperkalemia is peak T waves, flat T waves in most leads is hypokalemia. But what if it's in contiguous leads in a certain area of the heart? That is also considerable for ischemia. Okay? And then biphasic T waves. The T waves go up then down or down then up. So these T waves, for instance, are going what? They are going up then down, right? And up then down like a roller coaster is bad. You don't want them to go up then down. That means they have an area of depolarization first, right? Which means it's abnormal, which means there's ischemic tissue. So you have up then down T waves that are biphasic. That is considered a STEMI equivalent. That is the same thing as a STEMI. No, there's not ST elevation, but you have these what are called de Winter T waves. All right? Sorry, so Wellens T waves. De Winters are also, but the Wellens T waves have this up then down appearance. It's like a W, right? At the last half of the W at least, right? So it's that up then down piece that is considerable. And it's in V2, V3. That is where we're looking for these. All right, you can see they're up then down right there, right? And then then it progresses to these symmetrical T waves. Those are considered Wellens T waves. Okay, so that's the idea behind T waves. So T wave inversion, yes, is a sign of an NSTEMI, but if you have this symmetrical T wave inversion like this and V2, V3, that's actually considered a STEMI, right? Like, well, I don't see ST changes. It's because STEMI is an older term, right? We have new things now. We have other things that describe a STEMI. A STEMI happens when you have complete occlusion of the coronary artery, right? So your complete occlusion of the coronary artery could cause a STEMI, it can cause left bundle branch block, it can cause scarbosis criteria, it can cause de Wellens T waves, it can cause de Winter T waves, it can cause all these different equivalents to ST elevation. All right, so J points. As we mentioned, the J points are what you can grab the ST segment from, and if that's going up or that's going down, that's considered a ST elevation or ST depression, right? And again, you have to let the QRS finish. Sometimes the QRS isn't finished. You've got to make sure that it is absolutely done, and then that's when you're going to pull up the T wave right here. Okay, and this is where you measure the ST elevation. And if it's more than one small box, that's usually considered ST elevation, except when you're male or female and you're in V1 or V2 or V3, sorry, and then it depends, right? So if you are male and it's like 2 millimeters, and V2, V3, that doesn't meet criteria. It has to be more than 2.5, specifically in V2, V3. Everything else though, but in lead 2, if you have 2 millimeters, that is equivalent to an ST elevation MI. Okay, so that's the idea. So greater than 1 in all leads, whether you're male or female, right, all the way across. But once you start getting to V2, V3, that's where we pump the brakes. So we're going to say, well, is it more than 2.5 or more than 2 based on male or female? It's just a way that it's measured. That's they found in the data. That's what actually leads to an MI or doesn't. Okay, and again, it must be in 2 contiguous leads. You can't just have it in V2 and then it's not in V3, for instance, or it's not in V1. So you want to make sure it's in 2 contiguous leads. And then concave versus convex T waves. You can see this is a little smiley face. If it's concave like that, that is fine, right? But if it's upright and it looks like this portion here starts going upright over here, all right, a good example. You can see that's a little tombstone right there. That is obviously bad. That's a frowny face, not a sad face, or not a happy face. So that is a sign that your T waves are good or not, based on whether it's concave or convex. Other things are if it's like downsloping like this, that's not good. If it's horizontal, that's not good either. Okay, but if it's upsloping, except for V1 through V4, then that's perfectly fine. If it's concave like that, that is a normal variant. Okay, so the ST segment, we're not going to spend too much on the ST segment. It just explains why you have ST elevation, ST depression, right? Because it was always when I came out of nursing school, I was like, why? I was like, just because it is. And I couldn't accept that answer. So I had to figure out why it was the ST segment elevation. And it's because, when you have a ischemia, again, it's releasing positive energy, right? Because it's not able to return back to its baseline appropriately. So it's constantly releasing this positive energy when you have just like a partial damage to your cells, right? So we have partial damage to your cells right here. It's going to cause this positive energy being released at all times. So basically it's like CPAP for your EKG. It raises everything by 5 millivolts, right? And then when everything is depolarized 100%, then it's going to be yoinked back down to where it's negative, right? So, but then it goes all the way back up to its CPAP. It's like turning the machine off, right? So so really in ST depression, it's actually everything's elevated. In ST elevation, everything's depressed except for the ST elevation segment. So this explains why. So I'll let you peruse this, but the idea is that you have this partial thickness. That's just part of the wall of the heart is blocked, right? Is dying. And of course we have to intervene because, for instance, your LAD right here is feeding the outside of the wall. It comes on the outside of the heart, and then it feeds down these little tiny little vessels, and then it returns back to the venous circulation. So when you have an occlusion, right, over here, the subendocardium, or this layer right here on the inside, is what dies first, right? And of course, what's worse is then the whole thing gets dead, right? You have what's called a transmural MI over here on the left, right? That's transmural, mural meaning wall, right? It's going through the whole thing. That's a STEMI, right? Because in STEMIs, you have no depolarization happening. It's not partially depolarizing like it's broken. It's a dead muscle. There's nothing being released. So everything in that area, it comes down to 0 no matter what, right? So the whole thing goes down in that area, but then when everything is depolarized, it actually causes a little elevation. So that's why you get ST elevation in a transmural MI. All right, so that's the idea behind knowing that ST elevation is the whole wall, whereas ST segment depression is just the partial wall is occluded. Okay, so this is a summary slide of all of our ST segment changes. Okay, so we have ST segment elevation and we have ST segment depression, right? So ST elevation, that's considered abnormal. Or sorry, what are some normal variants? You can have ST elevation in your precordial leads, but they are never depressed. Whereas in your limb leads, you can have a little bit of ST depression, but they are never elevated. So that's why when we looked at the criteria, if it's greater than 1 millimeter of ST elevation, absolutely that is ST changes, right? And again, pericarditis we'll touch base on, but that is situation where you have ST elevation and a lot of leads. It doesn't follow the pattern that we expect, right? Benign early repolarization we touched on. That's just a normal variant where you have this ST segment that returns back to normal. Sorry, it doesn't actually go all the way down. I have an example here shortly, I thought, right here. So it looks like ST elevation, but it's not, right? So it's a variant, usually found in younger people. All right, and then left bundle branch blocks. So that's, and paced rhythms. When they have that, you have to employ what kind of criteria? That's the scarbosis criteria, where you have to look to see is there concordance or discordance, and is there a lot of ST elevation, right? That is something that we can assess when someone has left bundle branch block or a paced rhythm, because otherwise it's going to be hidden, right? You're not going to be able to see the classic changes. Okay, it is a STEMI equivalent. All right, and then LV aneurysm, we'll talk about that as a complication of a MI. But so a recent MI might have this complication. That's where you have this large, deep Q waves that persist after the MI. And then Brugada, that is it's a rare genetic situation that might happen that shows some ST elevation. So it's just something to consider. And then ST depression, that's 0.5 millimeters. That's all you need, 0.5, to say that they have ST depression, right? So the posterior wall MI we'll touch base on. That's when you have ST depression in V1 to V3. That's very concerning that they might have a posterior wall MI. So whenever you see ST depression in the V leads, like right here, see that ST depression, that's very concerning, right? So that's something that we got to be eyeballing, because that is actually ST elevation in the posterior leads, which is another EKG we can do. And then De Winter T waves we talked about, that's also a STEMI equivalent. That's this piece right here that I promised I had a picture of before. That's where it looks like ST depression, but it's actually a occlusive MI. It's actually a STEMI equivalent. And that's specifically in V2, V3. All right, so it's upsloping. It's like that's the only time where the smiley face is not good. But again, that's ST depression smiley face. So that's a way to think about it. It also goes up and down too, which we said was bad. And then digoxin can cause this little scooping of the ST segment. And you notice it goes down then up, so it's not as serious as an up then down, like a Wellens T wave, for instance. And then we have hypokalemia. It kind of cause a little bit of ST depression, but it'll be global. It wouldn't just be one specific section of the heart. It wouldn't just be 2, 3 AVF. It wouldn't just be V1 to V4. All right, and then there's other variants that they have, like right ventricular hypertrophy. They have SVT, and that usually gets resolved when we turn those things around. All right, so you got Q waves that are deep. You got these this Q wave that's really, really deep that persists for a long time. That's considered LV aneurysm. That's genetic with a Brugada syndrome. These tombstones here, that is considered a bad situation, right? That's definitely not a smiley face on the ST segment. That is a profound ST elevation. Okay, again, upsloping, like this convex piece is not good. Downsloping is not good. Horizontal is not good. The smiley face, we'll take that. Okay, so the Q wave, this is a sign of a transmural MI, of the whole wall being affected. Okay, it was once thought that this was fine. It's like oh, it's a sign they have an old MI. But then come to find out, it's like, after the research came out, it's like, uh-oh, that's actually an acute MI happening right now in front of my eyes, right? That is not a good sign when you have Q waves, right? And yes, they can persist, like we said with the LV aneurysm, but in this case, if you had to see this Q wave developing in front of you over a couple hours or like a day or two, that is a sign of a active MI in front of you, right? And what we said the criteria was greater than 1 box wide, or it's deep, right? How deep? 25% compared to the whole height, right? If the whole height is, let's say, 12 millimeters, right? So that's an odd number, let's just say 16, right? So if it's 16 millimeters from top to bottom, where was a good one at? So top to bottom, it's 16 millimeters. There's another good Q wave at, okay, over here. So you have the Q waves, and just this one, all right? So 16 millimeters. If we measure it from top to bottom, it's 16 millimeters. And this bottom section is more than 25%. What's 25% of 16? 4. If it's more than 4 millimeters, that's a pathological Q wave. That is concerning. That needs to be addressed. Okay, so this is greater than a box over here, so that is also pathologic. All right, so those are other clues that you might have a MI developing